Good afternoon. It's a great pleasure for me to be here today to present the results we have obtained in our lab in the last years. Well, this is the outline of my presentation. After an introduction, I will speak about Methicillin-Resistant Staphylococcus aureus, is MRSA, epidemiology, and the prevalence clones circulating in our country. Then I will go directly to cystic fibrosis, trying to show what is the diversity of Staph aureus strains in patients attended in a reference center. And then we will go to the genome plasticity of Staph aureus as an adaptive strategy in lung colonization. As you know, all of us are colonized by Staph aureus in a certain moment of our life. It is one of the most common causes of skin and soft tissue infections, but it can also cause invasive disease as bloodstream infection, endocarditis, meningitis, and toxic shock syndrome. Amongst methicillin-resistant Staph aureus is a special kind of staph that is important as a cause of nosocomial infection. It was important. Now I will show you what is methicillin-resistant Staph aureus. It's a special kind of staph that had acquired a mobile genetic element called staphylococcal chromosome cassette, MEC. This mobile genetic element carried the gene MEC-A that encodes a PVP that it is PVP2A. This protein is not inhibited by beta-lactam antibiotics are all the other PVPs of bacteria. So the bacteria that carries this gene is resistant to all beta-lactam antibiotics, except the new line of antibiotics, anti-MRSA, ceftaloridine, and ceftobiprole. So, as we have said today, the antimicrobial resistance is a global crisis that must be attended with the greatest urgency. So in the year 2015, the World Health Organization released a document where it states that there is a list of pathogens that must be attended in concerning research, discovery, and development of new antibiotics. And methicillin-resistant Staph aureus is included in this list as a high priority pathogen. Since the 60s, methicillin-resistant Staphylococcus aureus was considered a nosocomial pathogen. It is to say, if you, after the introduction of methicillin for the clinical treatment, 1 year later, the first strain appeared, the first resistant strain appeared. And it became endemic in hospitals. So if you go to, at that moment, if you go to a hospital, you had a high risk to acquire an infection of methicillin-resistant Staph aureus. But in the 90s, it appears a different kind of Staphylococcus aureus that is called community-acquired Staphylococcus aureus. And this kind of infections was described in healthy people, in very young people, without the risk factors to have MRSA. The previous risk factors were to go to hospital, to have a certain kind of indwelling devices, or to dialysis or treatment in the hospital. So this is the appearance of this kind of strains causes great concern because this strain seems to be more virulent than the others. So when we compare community-acquired methicillin-resistant Staph aureus and hospital-acquired strains, there are different lineages. And also, they carry different mobile genetic elements. I forgot to explain you before that there are more than 10 different mobile genetic elements that carry MEC-A gene. So the community-acquired methicillin-resistant Staph aureus carries the element 4 and 5, and the hospital-acquired 1, 2, or 3. But one of the main differences are that normally the community-acquired strains are more susceptible to other families of antibiotics. By contrast, hospital-acquired methicillin-resistant Staph are multi-resistant. Additionally, as I said you before, the community-acquired methicillin-resistant Staph are particularly virulent. Well, at the beginning of this emergence in the world, it was clear that there are different types, different clones of CA-MRSA that were distributed. STF30 were first described here in Australia, but then it began to travel to all the world. In the States, ST8 was the prevalent clone, and in Europe, at the beginning, ST80 was the first clone, one of the first clones described there. And as you can see here, in our country, there were no description of this kind of bacteria. The first reports were of our lab, where we described in the first of description was a case of meningitis. As you know, Staph aureus is not a common cause of meningitis. It's not of the most frequent bacteria that cause meningitis. And we study the strains causing meningitis, and we see that it was an ST5. Then other studies also demonstrate that the ST5 was also circulating in the eastern region of Argentina, and it also was colonizing healthy children. We performed a study where we surveyed all the 5 years old children that was initiating the kindergarten, and we try to find if they have or don't have as colonizer MRSA, and we find that also this clone was present in healthy children. After this, in this study, in those two studies, we also found a little proportion of the clone ST30. Well, but the guidelines for treatment of Staph aureus said in 2009 that the empiric treatment for the treatment of soft tissue and skin infections is the use of beta-lactam antibiotics. As you know, beta-lactam antibiotics is not useful for MRSA. And for the treatment of invasive infection, we have to use other families of antibiotics. But in these guidelines, they said that that we do not know which is the prevalence of skin and soft tissue infection caused by CA-MRSA in Argentina. And what happened was that the infectious disease doctors were seeing more and more very severe infections, skin infections, that were treated with antibiotic, with beta-lactams, as it is indicated in the guidelines, but the evolution of those patients was a very bad outcome. So they were thinking that if it was necessary or not to change the treatment. Well, there are some slides that are missing. I don't know what happened, but I will tell you the story. It's something very strange here. Well, what happened that we performed 2 studies, one of invasive infections and the other, it was skin and soft tissue infections, multi-center study in collaboration with the Argentinian Society for Infectology and our lab at the University of Buenos Aires, and we demonstrate that ST5 was no more the prevalent clone. We detect another new clone that was ST30, that clone that was first described in Australia. So after these studies, we also determined that the prevalence of MRSA causing SST infection was 70%. So after this study, the guidelines for the treatment of this kind of infection was modified. So the new clone, ST30, was more virulent or not. For this reason, we carry out a new study where we analyze the virulence gene profile, and we study this strain comparing ST30 and ST5 in animal models. We determined that virulence gene profile of ST30 could represent an advantage for the establishment of a localized infection and the dissemination to other tissues. ST30 strain exhibit higher virulence in 2 animal models. So finally, we can conclude that ST30 is a high-risk clone because it was so successful that this clone can displace the previous prevalent one, ST5, and it is also more virulent than the previous one. So we can denominate a high-risk clone. What about cystic fibrosis? As you know, cystic fibrosis is a genetic disorder that is very frequent in the Caucasian population, and it is associated with the alteration in the transmembrane regulator, CF transmembrane regulator. It is a multi-organ disease, but one of the first organ that is damaged is the lung. As you can see, there is a lot of mucus that accumulates in the airways, in the respiratory airways, producing a progressive pulmonary damage, persistent lung infection, and respiratory failure. What about a microorganism that appear in these patients? This is a figure where you have the age of the patients, and just from the beginning, the first line is Staph aureus. It's one of the first colonizers of the respiratory airways of these patients. And methicillin resistance also is present very early, but the rate of presence depends on the rate circulating in the general population. Additionally, this environment is very complex in the respiratory airways. We have another microorganism, we have the immune system, we have mucus, and we have antibiotics because these patients receive a lot of antibiotics. So there are a lot of adaptive mechanisms that are developed by bacteria so as to persist in this environment. Well, this work was carried out in collaboration with the Respiratory Center at the Hospital de Niños Ricardo Gutiérrez. This is the National Reference Center for the treatment of CF patients in our country, and it is the center that receives more quantity of patients. We have 2 questions just at the beginning. Which was the prevalence of methicillin-resistant Staph aureus in these patients? And which are the main MRSA clone present in the lung of CF patients? Does the high-risk clone previously described is present in those patients or not? And which is the risk? Well, to answer the first question, we developed a prospective study of 1 year, and we determined that the prevalence of methicillin resistance was 34%. The median age of the patient was 7 years, but in this hospital, they attend patients from the newborns up to 18 years. So, which are the main clones? To answer this question, we perform molecular typing techniques, pulse field shell electrophoresis and multilocus sequence typing to all the isolates collected during this year. And what are our results show that there is a diversity of strains. These are, each line is a pulse field shell electrophoresis pattern, and as you can see, there are a high diversity of strains, different strains, but when we analyze the sequence type, applying multilocus sequence typing, we determine that ST30 and ST5, the two previous prevalent clones, were prevalent. It is to say that 50% of the strains belong to these 2 clones. But another thing that it was a very key finding is that 60% of these isolates, of these 2 clones, are multi-drug resistance. What is multi-drug resistance? That bacteria that are resistant to more than 3 different families of antibiotics. So this is a very big difference comparing what was previously described in CA-MRSA. As you remember, CA-MRSA were not multi-resistant. So this kind of stuff are different from the others circulating in the general population. And another observation was that there was an association between multi-drug resistant MRSA and chronic infection. So after this, we question which are the strategies developed by MRSA to persist in the respiratory airways. Because persistence of MRSA was demonstrated that those patients who are early colonized by this bacteria and who persist MRSAs in the lungs have a worse prognosis in life. They receive more antibiotics and they have more rapid loss of pulmonary function. So, to answer this question, we follow 4 different patients and we recovered the serial isolates of those patients. These patients belong to ST30 and to ST5. We compare those isolates first by pulse field electrophoresis and antimicrobial resistant profiles, and we can see that in each patient, this is patient 1, 2, 3, 4, these patients exhibit, and the isolates recovered from these patients exhibit undistinguishable profiles. But the antimicrobial resistant profile is different, so there is change in the genomes. The next step was to perform whole genome sequences of serial isolates of each patient. I will show you the results of whole genome sequencing to explore the intra-host evolution in patient 3. And then I will make the concluding remarks for the whole patients. So what we can show here is that when we analyze this is the first isolate of this patient, CF38, and we compare the sequence reads of all the other isolates to these isolates used as reference, and we obtain these phylogenetic trees that is constructed based on SNVs, on single nucleotide variants. So here we can see that the topology is a very branched topology, and those isolates that are in blue are recovered exactly at the same time, and those exhibit a different morphotype, and also different antibiotic resistant profiles. But all the other isolates that were recovered after CF187 grouped with this one, not with this one. So apparently, here we have an adaptative benefit compared with this other isolate. Well, we use sequence data to explain the antimicrobial resistant profiles of those strains. Here you have the date where the isolates were recovered and the name of the isolates. All of them were resistant to beta-lactams, yes. All of them were Methicillin-Resistant Staph aureus. The first isolate was not resistant to gentamicin. The first isolate was not resistant to gentamicin, but all the others, the serial isolates, were resistant. And we discovered that this isolate carried a mobile genetic element carrying a modifying enzyme. Then erythromycin all of them were resistant. They carry an efflux pump and a modifier enzyme. Ciprofloxacin. The first isolates were sensitive to ciprofloxacin, and the latest isolates were resistant, and we described that the mutation were in topoisomerase genes. What about tigecycline? The first isolate was susceptible, and the others were resistant, except this one. Do you remember? These both were recovered at the same date. We explained the resistance to tigecycline in the mutation in the gene RPSG that encodes a ribosomal protein, and also in an efflux pump called MEPAID. And we also recover the isolate resistant to linezolid because of a mutation in 23S rRNA. Well, if we pay a look of which was the antimicrobial therapy that this child of 7-year-old have received, we can see that the antimicrobial therapy was really complex. This patient received inhaled antibiotics, those that are over the arrow. They receive oral antibiotics and endovenous antibiotics, those are in the marked in a color. So, when we compare as conclusion the first and the last isolate of 5 patients, analyzing non-synonymous mutations and indels, we found that mutations were in different functional categories, and the main affected category was virulent disease with virulence, defense, and disease. And in second place was antimicrobial resistance. So we can propose that virulence, defense, and disease and antimicrobial resistance are genes that are mutated, but they render bacteria with a fitness benefit to survive in this complex environment. As conclusions, we can say that Staph aureus has a spectacular genomic plasticity to adapt to its host during chronic infection. Some mutations in virulence genes are involved in the switch from highly pathogenic Staph aureus into a less virulent form associated with persistent during chronic infection. No shared mutations were acquired throughout the course of infection within the 4 patients, suggesting that there is no specific mutation that could be broadly associated to all the CF patients. But we can conclude that spontaneous mutation in the presence of a high selective pressure of antibiotics are driving force to obtain bacteria with a fitness benefit. So antibiotic treatment has a strong impact in shaping the colonizing population. Well, this is the people who have worked in my lab in this project. Mainly Sol Haim, who is a PhD student that is going to finish this thesis. We also collaborate with Hospital de Clínicas and with Argentinian Society of Infectology. This work of the strains came from the Children's Hospital Ricardo Gutierrez, and for the virulence assays, we collaborate with Dr. Daniel Sordelli and Marisa Gomez. And for the whole genome sequence data, with the Universidad de Manitoba and its National Microbiology Laboratory of Public Health Agency Canada. Thank you for your attention.